Assalamu alaikum warahmatullah. Good afternoon, ladies and gentlemen. Our round today about lecture new approaches to forgotten techniques where innovations simplify tradition. This talk will be presented by one of the new stars of our department, Dr. Mohammed Abusayf. He is assistant professor, consultant ophthalmologist at the Department of Ophthalmology, King Saud University. Mohammed, yes.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's always a pleasure to stand at KK's podium. Before I start, Profani, thank you. So if I must start, then you are the son. We are your students. طيب, Bismillah ar-Rahman ar-Rahim. So my talk today. So my talk today will title A New Approach to Forgotten Techniques where Innovation Simplifies Tradition. Basically, the talk is going to be about lamellar keratoplasty, where how to improve utilizing them and how to overcome problems and difficulties in doing lamellar keratoplasty. So I have no financial disclosure. To start with, anterior lamellar keratoplasty is basically the selective corneal transplantation procedure. It basically spares the DM and the endothelium complex. Lamellar keratoplasty can be categorized into anterior lamellar keratoplasty or superficial anterior lamellar keratoplasty, or what's known as SALK, or hemiautomated lamellar keratoplasty, or what's known as HALK, and deep anterior lamellar keratoplasty, which is known as DALK. This categorization is based on the level of the treatment of the stroma. So SALK basically refers to the automated preparation of the donor as well as the recipient, while hemi or HALK basically refers to the, as the name implies, automated preparation of the donor, while manual preparation of the recipient bed, and DALK refers to the manual preparation of the donor and the recipient bed. So what are the, when and why should we use each procedure? So each procedure has its own pros and cons. SALK is technically less demanding compared to HALK, and HALK is less demanding compared to DALK. So utilizing the correct procedure for the correct indication and the prerequisites for the indication itself or for the procedure itself will give you the advanced lamellar keratoplasty outcome, and the standard is DALK, with a simpler approach and less complications, which mainly perforation and PK conversion. So when you look at a disease that can be treated with superficial anterior lamellar keratoplasty and you do DALK for that procedure, basically it's like killing a mosquito with a machine gun. So the indication for anterior lamellar keratoplasty can be tectonic, therapeutic, and optical. So almost every stromal pathology can be treated with the anterior lamellar keratoplasty. So why to bother? Though all types of anterior lamellar keratoplasty has a steep learning curve and it does demand a lot of technical experience as well as challenges. Why to bother and do anterior lamellar keratoplasty? It is an extraocular procedure, and for sure nobody wants to see such an image intraoperatively. So there is because we are not opening the DM or the DOAS layer, it's an outside the eye procedure, so there is risk of an infection, and also there is less risk of open sky related complications such as suprachoroidal hemorrhage and lens prolapse and intraocular content prolapse. In addition, it does provide better post-operative tectonic integrity, less endothelial cell loss and less rejection, as well as longer graft survival rate. And in case of re-DALK, definitely the outcome of re-DALK is better than re-PK, because you are not increasing the endothelial sensitization, such in PK. Larger and eccentrically placed graft can be done when necessary using anterior lamellar keratoplasty. It does have shorter healing time because of earlier suture, so it leads to earlier suture removal, less steroid, and less cataract and glaucoma complication. In addition, which is my favorite thing, is to utilize the same graft for two patients in case of very good endothelial cell count, or to utilize low quality grafts for anterior lamellar keratoplasty procedure. So to start with, superficial anterior lamellar keratoplasty, or as many references refers to as ALTK, is basically we use the ALTK system, which is automated lamellar therapeutic keratoplasty system from Moria, and I have no financial disclosure. So it utilizes a nitrogen gas turbine driven microkeratome to perform the lamellar dissection. And because the best way to do SALK, or superficial anterior lamellar keratoplasty, is using the automated system, the ALTK system. Many people exchangeably using ALTK for SALK and SALK for ALTK. So the prerequisite for superficial anterior lamellar keratoplasty is to have uniform or regular thickness, as well as superficial pathology in the first 200 microns. So why is this? What are the basis of this prerequisites? There is an inherent problems of the ALTK system. In deep corneal dissection, it loses its accuracy in depth detection. And in irregular corneas, because we are applanating the cornea, it does replicate the stromal pathologies in irregular cornea. However, the system allows for smooth interface dissection, more predictable and consistent dissection depth in the superficial layers. What are the indications? Basically, any anterior to mid-stromal corneal pathologies with regular corneal surface. So I will just go through a video which shows the ALTK or the SALK system, where it provides a smooth interface and predictable depth. Here we are applying the suction ring on the recipient, passing the microkeratome into the stroma to cut a superficial layer just beneath the pathology. And then we should use the artificial anterior chamber to mount the donor on top of it to produce an anterior cap from a donor cornea. So basically, you put the graft on and you stitches, and sometimes you can use bridging stitches, or you can use just a bandage contact lens to put the graft on. So what are the cons of this procedure? Because of the variable suction of the microkeratome passes, it can produce irregular edges, which is not circular, and this irregular edges might cause epithelial ingrowth and a mismatch between the donor and the recipient, as well as sometimes it causes a decentered cut, as you can see in this photo. So an additional technique, which is two-stage ALTK, was described, where you can basically do your lamellar cut initially, as you can see in picture A, put back the superficial layer again without transplantation, stitch the graft again, and go back later on in 6 to 8 weeks and do a vertical trephination so you can avoid the edges of the microkeratome and stitch your graft. This video showing the two-stage technique in which we are cutting the recipient cornea first. If you notice, this is rotatory trephine in comparison to the straight cut trephine in the previous video. So you would let's wait for this. So we're taking the cap back and stitching it. Trying to align the graft exactly where it was, put a bandage contact lens, and come back in 6 weeks to do a vertical cut using an adjusted refine. This is from Moria. This is adjustable refine. They have a reusable and disposable version. The reusable is a bit more accurate compared to the disposable. So in here, basically there is a potential interface from our previous microkeratome cut. You can peel off the anterior lamellar cap with just simple dissection using Sinski or any blunt instrument to allow for peeling off the graft or the cap. Now, basically using the same vertical refine that you use, you can put on the graft and avoid the inherent problems of the microkeratome at the edges at the graft host junction, and you will have your graft. So basically with the modified technique, you will have a smooth interface, accurate depth, as well as good alignment. So what are the limitations or contraindications or complication of SALK? Basically, if you have an irregular surface, you will replicate the surface irregularities into the interface. This is a patient who had ALTK. However, I'm not sure, the pointer is not showing well. Maybe you can see with the arrow. Here, the posterior surface of the graft is irregular, or the posterior surface here of the stroma is irregular. So the surgeon elected to remove the ALTK and do DALK, and the patient improved in vision. The other problems are very steep corners where you will end up with free cap or buttonhole, or inaccuracies in deep lesions, and you're limited to a small diameter with the microkeratome. Many studies showed that ALTK has been shown to improve the visual outcome in comparison to manual ALK. Then what about, can we do better? Can we improve the outcome? So this is a patient of mine who presents, she's 17 years old, female, presented with a vision of 2200, poor quality. It's post contact lens related keratitis, and you can see clearly that she has a scar almost bridging the pupil or the visual axis. The scar is at a depth of 180 to 200, and the topography is showing horizontal coma that affecting her visual quality. So we decided, because we don't have all the instrument for the ALTK, we decided to go for femtosecond assisted superficial anterior lamellar keratoplasty. Here you can see smooth dissection of the microkeratome into the donor cornea, as well as smooth dissection except at the area of the scar in the recipient. And you can see complete removal of the scar here after some dissection. And here you can see we are applying the anterior cap into the recipient bed with good alignment, and we put stitches. So basically, FALK made the procedure shorter. You don't need to do the 2 modified steps procedure. Okay, so here is the patient post-operatively. You can see that the interface is clear. This is early, that's why you see some stromal folds. And you can see here that the graft is aligned well with the recipient bed. Here is the topography of the patient post-operatively. So we moved from horizontal coma and almost 20 diopter of astigmatism into 9 diopter of astigmatism regular. We removed the 4 stitches at 3 months post-op, and the surface is regular. At 1 year and a half, after we removed all the stitches, her vision reached 20/40, and her refraction is toward hyperopia, which is good because she's young at the moment. To be honest, she has some surface irregularities at the moment that we can maybe tackle with laser later on. So which is better, FALK or SALK? Both of them are a way of treatment in the surgeon armamentarium. However, SALK will need, femto-SALK will need only 1 stage, while microkeratome SALK will need 2 stages. You cannot control the diameter here, while you can control the diameter in femto-SALK. Any questions, or shall I proceed with the HALK now? Okay. So, talking about HALK. HALK, basically, as the name implies, it's a hybrid procedure. It involves the automated preparation of donor using the ALTK system and manual preparation of the recipient using sharp closed dissection. What is the rationale behind HALK? Basically, is to overcome the limitation of the ALTK system in recipient preparation, while take the system advantage of smooth donor cap preparation. It also mitigates the risk of doing DALK in those cases. So basically, if you have an irregular recipient cornea, you can tackle it with sharp dissection manually and prepare the donor with the ALTK system. The indications are any recipient not suitable for ALTK system, anterior to mid-stromal pathology between 200 microns to almost 400 microns, or superficial stromal pathologies that have irregular or non-uniform thickness of the cornea, very steep or very flat cornea, and deeper lesions up to 150 microns from the DM. This is a case where scarring from pterygium, and this is a case where scarring from contact lens, deep scar, irregular surface, you can utilize HALK. So the three key principles in HALK is: one, accurate determination of the donor cap thickness based on the preoperative assessment of the recipient. So, because you need to talk to your eye bank, right? And you need to tell them the thickness that you need for your patient, unless you're preparing them inside your OR. The second key principle in HALK is the precise vertical trephination depth of the recipient, which usually use adjustable trephiners. The Hana trephin, the usable one, is very accurate, but unfortunately it's not available everywhere. The third concept is smooth interface dissection with dry, closed, sharp dissection. So basically, the first principle, determine your cap thickness. The second principle, do accurate vertical trephination. And finally, do sharp, closed dissection of the recipient eye. So here, after vertical trephination, we are using the crescent blade to sharply dissect the stroma in one plane. And I'm saying close dissection and dry to allow to maintain the same plane rather than stromal hydration. If you use the ALTK system here, because of the depth of the scar and irregularity, you basically replicate the scarring into the deeper levels, and the dissection, the depth won't be very accurate. Those scissors are Anwar scissors. They cut on one side and they are blunt, so they will mitigate the risk of perforation. And now we are confirming with pachymetry, applying your eye bank prepared donor cap or your on prepared donor cap based on your preoperative OCT assessment of your scar, and then stitch the graft. So what are the advantages of HALK compared to DALK and PK? HALK procedure can restore and adjust the central corneal thickness, providing the surgeon with flexibility to modify the refractive outcome later using various refractive treatment. In HALK, suture removal can begin as early as 6 months, and we can taper topical steroid early. Cap can be replaced if needed. There are no reported rejection cases yet in all published HALK cases. So on the outcome, from outcome point of view, the visual acuity, it's noted that the visual acuity of HALK procedure improved significantly over the first year and continues to improve over 7 years. This applies also to refractive outcome. Those are different HALK cases from the HALK paper, different cases, different pathologies where HALK was used to tackle the corneal scar issue. There were 2 failed cases, one related to herpetic infection post-op and one related to keratoconus fold, and we'll come to the fold. So when it comes to thickness point of view, in the cases reported, around 35 cases, the central corneal thickness to start with was around 490, and the central corner thickness at 61 months was around 560. The maximum cap thickness reached was 400, and the minimum residual stromal bed was around 160 microns. So you can go as deep as 150 microns from the recipient DM. So what are the complications or the contraindication to doing HALK? In case it is common that you might put a thick cap and you might not dissect deeply into the stroma. This might lead to graft folds or recipient folds, and unfortunately they are not, unlike DALK, they don't resolve spontaneously, and the authors reported removal of the thick cap, replace it with either a thinner cap or deeper dissection. Another case where the patient had stromal folds or recipient fold was a keratoconus case. Though the depth of dissection was even, the stroma in keratoconus is not as normal cases, and the response to the thick cap might be different at different areas. So there might be more pressure on this side compared to the other side, leading to a fold. That's why the authors recommended that DALK should be the gold standard for keratoconus. HALK Plus can be applied to a PK graft, and the authors reported 5 cases where they did HALK over a PK, and the survival rate over 5 years for the 5 PK cases was almost 100%, and there is no way you're getting 100% survival rate with 2 PKs in normal cases. So this is a video of the graph. I'll pass it for the sake of time. So what about stroma to stroma? It is well known that interface irregularities and scarring result from manual dissection. However, changes in an improvement in instrumentation, surgical technique, intraoperative OCT, anterior segment OCT improved the outcome. In HALK particularly, if you went back to the anatomy of the cornea, the keratocyte density is highest in the anterior stroma, decreasing posteriorly, which promotes rapid and extensive interface remodeling compared to predysmatic DALK. In addition, the loosely arranged collagen fibers in the posterior stroma might increase the scarring risk. How can we mitigate those 2 factors? First, the sharp manual dissection of the recipient bed, as well as the smooth donor interface cut using a microkeratome, would allow better interface alignment and reduce the risk of scarring. And there has been no evidence of clinically significant interface haze in published HALK cases. What about Femtosecond? Can we apply Femtosecond in cases where we don't have the microkeratome system, or maybe we don't have the adjustable trifines, or we're not that accurate? So Femtosecond laser was reported to be used in HALK, in which even it was used in an Avellino case, where the vertical trephination, it is well known that vertical trephination using femtosecond laser is very accurate. However, the interface or the lamellar cut of the femtosecond laser, it's not as accurate as the vertical trephination. So the first case was reported to do a vertical trephination, mainly here, to just reach a depth just below the scar, and then you can use your recipient bed, your sharp dissection to tackle the bed. And even further modification in cases with dense scar where the laser cannot do lamellar cut, you can do a donut shape cut. This is the case, basically a patient with the previous DALK for infectious keratitis that had a history of perforation, and then the surgeon during dissection had a DM perforation. So when the patient had another infection post-DALK, he elected not to reopen the interface because of the 2DM perforation. So decided to do femtosecond HALK, and here he overcome the scar by doing an L-shaped cut, as you will see in the case, to do vertical cut, and then just an initial cut at the level or just beneath the scar level, and then continued with sharp dissection. Basically, the femtosecond will guide you into your trephination depth. So the advantages are high accuracy at the trephination depth, and then surgical guidance to access the partially created interface. Okay, and then the donor preparation can be done using femtosecond laser on artificial anterior chamber with the same way, vertical cut, and you do dissection, or you can order it from an eye bank. Okay, I think the video is clear. So what about DALK? Any questions for now, or shall I go ahead? You have to ask questions to give me a break, guys.
Here we do most of our cases on ectasia cases. So it's not only the endothelial cell count in BKB, which usually when people do BKB, they choose a smaller size. And even if they are doing a bubble, they choose a smaller size in case they convert. So it's not only the endothelial cell count, but also the quality of the topography.
Yeah. Well, first of all, I agree with you, Dr. Omar. Most of our cases here are keratoconus, and doing HALK in keratoconic eyes is not optimum. However, in other PK cases, based on evidence, it did show good graft survival rate, indicating maybe because of the surgeons are expert, and to start with the graft is good, as well as the survival rate. The survival rate was up to almost 500% Kaplan-Meier at 5 years. Definitely, the cases are few, and they need more number of cases to look into this.
But 5 years in survival, this applies when someone is treating malignancies. 5 years, they go back to the patient. If the patient is still alive, after 5 years, they consider it as survival. When we do a graft, we want the graft to last lifelong. And the other point is skills of the surgeon cannot increase the endothelial cell count. Maybe one thing is that if to start with, they are doing very good quality grafts, above 3,000, for example. And then when they count it, it's like 2,700. I don't know. I cannot imagine this in this country at all. Then they think that this is very good count to replace. Then maybe they can, if the shape of the cornea is okay, they may choose to do this approach. One image when they did this LKB on a keratoconic patients, the lens was white.
Which case? Let me see.
Yeah, there.
This was. To be honest, I'm not sure which case is this, but I remember that when they removed the graft, that what they did is they did cataract. So this is not pre and post op. This is all keratoconic patient who had folds. Okay, so
no, I'm curious about this white. This must have been an intumescent cataract that really needed something.
I know what you mean. What I'm saying is when the patient did the surgery, I guess the lens wasn't that white, and then when they've seen the patient post-op, they've noticed the extreme folds in the residual stroma. They've done DALK for the patient. They removed the HALK, and they've done DALK for the patient. I think they did cataract surgery as well. It's in their paper.
Yes, and one thing is what to expect, because this is ectasia case, and to just put, for example, 300 stroma over an ectatic cornea, they should anticipate that this is not going to add any tectonic stability to the eyes. It will
Correct.
not make the eye strong.
Yeah, that's eventually what was their conclusion.
So what is the point of doing something that they should know it is not going to work?
Yeah, the thing is, that's what they realized at the end, and that's what was one of their recommendations.
I think they should have realized this from the beginning.
Yeah, maybe. Yeah. All right. Okay. Thank you for the break, Dr. Omar. Now we will go back to our talk. We can even discuss this further. So basically, the last procedure in anterior lamellar keratoplasty is DALK, and DALK, based on Sarnicola classification, is broadly classified into predysmatic DALK and big bubble DALK. However, after DUA's layer introduction, and now the classification is a bit even more confusing. Now, the real big bubble or the dysmatic bearing big bubble DALK is called TALK, or total anterior lamellar keratoplasty, in which the only remaining layer is the dyscement membrane. And all the previous manual technique are now underlying DALK, and the real new term is STOC, or subtotal anterior lamellar keratoplasty, which was previously wrongly identified as dysmatic DALK. This is basically where DUA's layer is still intact. So comparison between DALK and a PK from visual outcome and safety outcome. The safety and the graft longevity, DALK is superior to PK in safety, rejection rate, graft survival rate, and endothelial cell loss in high risk eye and in low risk eye as well. What about the visual outcome? Dysmatic DALK showed based on many papers that it is equivalent or even sometimes in other cases superior to PK. However, pre-dysmatic DALK is always determined by the amount of residual stromal bed thickness. If you removed most of the stroma, leaving less than 20 microns, the result or the outcome is comparable to PK. If you leave 60 microns, the outcome is comparable to big bubble DALK, and the poor or the less VA was with whenever you leave 80 microns or below. So pre-dysmatic DALK showed delayed visual recovery. However, the long-term VA and refractive outcome are comparable to dysmatic DALK. Keeping in mind, the deeper you go, the higher risk of perforation that you will face. So as we said, DALK is considered the gold standard surgical treatment for advanced keratoconus. So the very well-known technique for the big bubble DALK is the Anwar big bubble technique, which is originally described by Anwar. Basically, you do partial trephination followed by a bevel down 27 or 30 gauge needle inserted at the trephination edge, and then the needle advances into the deep stroma and we inject air. The limitation of this technique, the original technique, is basically superficial injection risk because of you cannot see actually the depth that you are working with. In addition, sometimes you are faced with stromal emphysema, as well as high IOP or prolonged high IOP period while removing the superficial anterior lamellar layer, prone the patient to Uretza Valley syndrome. So a modified technique was introduced to basically do your trephination as deep as possible based on your pachymetry and your pentacam, and then remove the anterior stromal layer and introduce your needle. This will leave you, let's say that you have a 500 micron stroma and you remove up to 300 microns of the stroma. This putting the 27 gauge needle or the 30 gauge needle itself in the stroma will guarantee you to be at a depth very close to the DM, and this is one of the most important successful factor to get the big bubble. One of the tricks that I do to avoid having problems or perforation is I mark my needle. I just basically introduce my tunnel, and then I followed this with, sorry, the video has some lag, and then I introduce a cannula, and then I go in deeper to get my big bubble. Just let me wait for it. Sorry. So you see that my mark here, and then I go with the cannula. Okay, then you get the big bubble, and then you continue as usual. So what about pre-dysmatic DALK? I believe that pre-dysmatic DALK or manual DALK mastery for any anterior segment surgeon is crucial in case of cases that you fail to get the big bubble, or cases where big bubble is unfeasible, like deep scarring, post-hydrops, therapeutic and tectonic needs, or high-risk cases like herpetic. Then mastery of big bubble DALK is important. I usually use manual sharp dissection technique. Initially, I've learned from Dr. Umar during my locum here how to do stromal hydration, and it's a fantastic technique, to be honest, and it's very safe. And then I've learned as well as the sharp dissection technique, where you don't introduce any fluid into the eye and dissect layer by layer. And the key factor in the pre-dysmatic DALK is to control the eye pressure. Always look at the eye as a balloon, where if the pressure is low, then the perforation of the DM, even if you perforate, it will not extend, and even the risk of perforation will be low. This is a video of a manual DALK. So finding the first plane, followed by crescent blade dissection, and basically the same until deeper layer. So what if you perforate? So the ALK outcome with intraoperative deimperforation, there is a study based on 500 cases done over 10 years where the risk of perforation was 80%. They had, 80% of the perforated cases had microperforation and 15% had macro perforation at different stages. And the outcome at 1 year and 3 years showed that there are no increased risk of graft failure, graft rejection, or subsequent surgery. And the visual outcome was equivalent to uneventful DALK. And this basically tell you, try never converting and try to finish the case as much as possible as a DALK to reduce the risk of perforation. What about femtosecond laser in DALK? So femtosecond laser is well known for its accurate and vertical trephination. It was used to shape the corneal incision. However, the results are similar between shaped PKs and straight cut PK, or the evidence was not compelling. It's shown that the femtosecond laser is safe and more reproducible, especially if you're using complex graft host shape, and more evidence are coming. The initial result of lamellar cut is not that encouraging. It's inaccurate and mainly for keratoconus cases. So in scar cases, always the surgeon is in doubt, use femtosecond laser. Different platform have been used for femtosecond DALK. And you can see from this graph that the rate of PK this is from the Eye Bank of America, the rate of PK is increasing significantly, the rate of EK is increasing significantly, while the rate of PK is decreasing significantly over the years for the same indication. And this tells you that EK is really working. And one of the main factors for this is the standardization of the technique. Different technique has been described, different methods, all of them have been studied well. Okay, so what about shaped DALK? So can we get shaped DALK? Can you do mushroom shaped DALK or a top hat DALK? Definitely you can, but the results still not compelling. Then what about can you do something else with the femtosecond to improve DALK? Definitely you can do your lamellar cut, at least to get a deeper cut. And one point is large diameter DALK based on studies from Bozen showed very good result, better visual outcome compared to regular DALK with no increased rejection rate. He used 9 millimeter diameter anterior cap. Basically, he cut a 9 millimeter, remove the do big bubble, remove the cap, and then cut only the central 6 millimeter, leaving a mushroom shape. This has been shown to have very good result and a good refractive outcome. So in addition, femtosecond DALK showed less risk of perforation. So, and then some other surgeon used the can we increase the risk of big bubble DALK? Some other surgeon used femtosecond laser to introduce a tunnel into the stroma to improve the success of getting the big bubble. So trying to compile all this together, so to see if really femtosecond laser are really helpful. A study was conducted in Singapore on porcine eyes using the LDVZ8 platform to trying to get a mushroom configuration as well as a lamellar cut and to reduce intrastromal tunnel. So basically, we tested this on porcine eyes initially, and it showed accurate laser cutting. And then on a clinical series of 10 eyes with different type of corneal pathologies. This case is Avellino. This case is mucopolysaccharidosis. Sorry, this case is lattice. This case is mucopolysaccharidosis. This case is apical scarring in keratoconus, and this is granular, and this is Avellino, where the femtosecond laser was used to cut in this shape. I'll go to the video straight ahead. So basically, you use the LDV femtosecond laser to cut the donor cornea on an artificial anterior chamber, and then use the femtosecond laser on the recipient to cut a mushroom-shaped keratoplasty. And here is the technician manipulating the tunnel to the side. And here you can see that the laser is cutting the intrastromal tunnel, as well as the lamellar cut, followed by the ring and the vertical trephination cut. This picture is from the recipient cornea, and this is from the settings of the recipient. So we cut the cornea full thickness in the recipient. All those pictures all from the donor cornea. Yeah. And we cut the donor into full thickness. So it was done on 10 cases. The success rate of getting the big bubble on those cases was 100%. All 10 cases achieved the big bubble. Different type of big bubble. Most of the cases were type 1 big bubble, and the remaining cases were type 2, and one case was mixed big bubble. So basically, you've shortcut the whole procedure, which might need very long time, including doing the customization of the shape, if you want to do this manually, removing the anterior stroma, doing your big bubble. So the only part left for the difficult part of the procedure is the stromectomy, and then so the clinical outcome, we managed to remove all the cap from all the patients, including in all scar cases. And here is the post-operative outcome of all cases. The patients are around 1 year now, so that we cannot 100% judge on the refractive and visual outcome. However, it was very encouraging. Most of the patients had cataract, so they would need cataract surgery, and we can see that the KM, or the average K, as well as the Kmax, in most of the cases went to almost normal range. Okay, so now we finished from anterior lamellar keratoplasty and the application of femtosecond laser into them. I'll talk about posterior lamellar keratoplasty, and I'll focus on mainly one technique that was really forgotten, which is the deep lamellar endothelial keratoplasty. I'll start this with a case. So this is a patient presented with herpetic keratitis and stromal milt. The patient progressed into almost full thickness milt of the stroma. The surgeon elected to do DALK for the patient, and eventually, after almost a year, the patient did well. However, and patient VA was 618 with contact lenses. This is the best corrected VA. If you can see here, it's clear clinically that there is a deep scar just being at the residual stromal, the bed of the recipient. This is common in herpetic. You see this in herpetic. So after a while, maybe 1 year or so, the patient presented with gradual corneal edema that increased significantly. So the differential was, is it HSV recurrence? It is stromal rejection? Is it graft failure? And since the patient was on prophylactic treatment and there was a background of Fuchs endothelial dystrophy and previous DM detachment after DALK, history previous DALK, gradual course, and visual deterioration, it was deemed that this is graft failure. Here you can see the stromal scarring evident in OCT, as well as the slit lamp photos. So what would you suggest to do in this case? Basically the options is DMEK, DSEK, or other procedure. I'll go back to this case later on. So what is DLEK, or deep lamellar endothelial keratoplasty? Is basically replaced of the filled endothelium as well as the DM and the thin posterior lamellar stroma by a healthy disc of donor tissue, either DSEK or DMEK. It was initially described by Millis in 1998 and modified by Terry. It was done manually, so it was useful in limited but distinct indication, like selective removal of posterior stromal pathology, retain deep scarring after DALK, endothelial failure after DALK, or to enhance the AC depth in filled DSEK with PBK and NaCIOL. So this is the technique. So basically it involves two parts: host preparation and then donor preparation. The donor is DSEK, and the host preparation include posterior vertical cut. Imagine you want to do posterior trephination as well as lamellar dissection. However, the posterior trephination device was not available, so some surgeons elected to use scissor. I will show you a video for the case. This is the initial procedure. So this is like 350 microns intrascleral depth with full dissection of the stroma, followed by entry into the AC, and then using a curved scissor to cut the posterior stroma to tackle the scar as well as the endothelial failure. This is followed by DSEK. putting the graft in. You can know from the technique that this is an old technique. I guess nobody's doing the folding of the DC graft nowadays. Readjusting of the graft. It is doing something that I'm not sure what is it. So this is post-op day 1. This is post-op day 8, and the vision is 22/800. So in 2015, so Bruce Allen decided to revisit this technique. So he published a case where he used the intralaser femtosecond laser platform in host preparation. He included 7 eyes. The indication was 1 case of contralateral DSEK and incomplete clearance of the opacity. So this is a patient had DSEK, idiopathic copper deposition into the cornea. They did DSEK for the patient, but the patient didn't completely clear. The other 2 cases was like failed previous DSEK with ACIOL, and the main aim in their study was to increase the distance between the transplant and the ACIOL. 4 cases were post-DALK, in which 1 case had mild but visually significant residual pre-desmatic scar, and 3 retracted and irregular DM endothelium complex secondary to persistent post-operative double AC after the procedure. So what was the outcome? Femtosecond was used in all cases to do the vertical posterior cut. However, for the lamellar cut, in DALK cases, you do not need to create a lamellar cut because you already have a lamellar cut into the cornea. You basically need to do the corneal cut, the vertical cut. And though no lamellar cuts were done in the DALK, as I said, so how was the femtosecond laser performance? The vertical cut was good. There was no issue with it. However, the lamellar cut was difficult, and they need to use scissor to cut. And so the surgeons or the authors came out with a conclusion that the lamellar cut should be done 1 week ahead from the procedure itself to do the lamellar dissection, and then 1 week after do the vertical cut. And they claim that the dissection will be when you do both procedures at the same time, the lamellar cut as well as the peeling, you will lose the counter traction of the lamellar dissection if you did your vertical cut. So nothing supporting the stroma at the edges to help you with the lamellar dissection. The result, there was no intraoperative complication. Post-op day 1 case had detachment, DMEK, and this is here in the photo. You can see the difference. So this the same patient. In 1 eye he had DSEK, and in 1 eye had DLEK with DMEK, DLEK with the replacement of the endothelium TM complex. So back to our case. So we elected to go for the same procedure for our patient. However, we elected to use the femtosecond laser platform from the LDV because of its intraoperative OCT. So marking is done before ducking to find the DALK center. And then we're using the liquid patient interface rather than a planating interface. The previous DALK diameter was 8 millimeter. So the DM rexes, the desmatorexes is around 7.3 millimeter, and we can adjust 360 or almost 360 the vertical trephination of the cut. Here you don't need to do lamellar cut, right? Because it's a DALK case. You already have an interface, and I will show you a paper that we published. Okay, so next we'll go to the surgery. Here is the surgery. We'll go in. Oh, sorry, I've repeated the video. Here is the surgery. Removing the epithelium to improve visualization. And then removal of the DM endothelium posterior stroma complex. You will still see some difficulties in the vertical cut. Then we'll use a vitrectomy scissor to cut the edges. So this area was hazy, so I guess the laser didn't cut very well through the area. So you still need your curved scissors, though you're using femtosecond laser. This is followed by pull-through endoglide assisted endoendemic. But in my personal opinion, I believe in such difficult cases, maybe endoendemic will have more control. And then gas injection was done. How is the visual outcome? So the patient vision improved after almost 2 months, 269, best corrected, the pressure was controlled, and you can see the clarity is restored and the patient is happy. So we've done this technique over 9 cases with different posterior stromal scar, and this paper was recently published where we use the LDV femtosecond laser platform to cut. All those cases are post-DALK, so we didn't need to do an interface dissection in those cases. So ZA, the platform is basically the key advantage here. So basically, what's the difference between our paper and Bruce Allen paper? Here we are using intraoperative live OCT guided depth adjustment. You can adjust the posterior vertical trephination at different area and different meridians. We are using a liquid patient interface, so you're not applanating the cornea. And the clinical experience is until now is good. 9 cases were done. However, the intralays used a planating interface, and you cannot adjust anything. You will based all your judgment based on the prefix depth from your pre-operative OCT. Really, I want to really thank you for waiting for all this time. So basically, lamellar keratoplasty need a mindset shift. You need to transition from full thickness surgery to lamellar surgery. The key formula is find the correct procedure for the correct indication to get a desirable outcome, ease of surgery, fewer complications. Consider ALTK, if not HALK and then DALK. The advantage of lamellar keratoplasty are longer survival rate compared to PK, lower complication, and improved outcome due to advancement in understanding, instrumentation, and imaging. Femtosecond laser can be helpful in DALK in trephination and lamellar in SALK in trephination and lamellar cut. In HALK can help with trephination and modified donut cut in case of scar. DALK it can give you the compelling world of having customized edge lamellar cut as well as intrastromal tunnel. DLEK can help with patients who had like interface opacities or posterior stromal scar from previous inflammation or infection after DALK. Those are my references, and I would like to thank you for waiting all this time. Thank you. Any questions, Dr. Amr?
Yeah, thank you very much. A very nice talk, really, and comprehensive. I'll share some comment about what you did, cutting a disc of the posterior cornea. I thought of doing this in cases who had lamellar with residual stroma of irregularity, and some of them were post-hydropsis, for example, assuming that they had good endothelial cell count, but with a significant irregularity and scarring in the center. So I thought of cutting a disc using the femto laser. Unfortunately, we had the intralays, and you cannot do an intraoperative OCT, so I had to rely on the OCT from MS39. And what happened was I cut a nice disc, and I had to go into the stroma to make sure that I include the scarred area and the irregular area. But what happened was that the adhesions between the disc, between the recipient and the donor was so strong, I had to pull a lot in order to detach it. And the cut, when it went into the recipient, the donor stroma got hydrated with time, and posterior stroma swelled posteriorly. The recipient's endothelium was obviously not very good, and the patient had a hard time of the endothelial cell covering the back of the. So maybe unless you have really an OCT that can guide you, or maybe it's better if you cut it manually. Yeah. Regarding, but it is very nice. I think your results are excellent. Probably rethink of doing my cases if we get a better Femto machine. Yeah, the other thing is regarding the lamellar. We had a debate in the last KKESH meeting about keratoplasty in ectasia. I'm strongly convinced that BKB is not okay in ectasia at all. And if so,
not okay.
BKB
Is not okay.
Is not okay at all. It should be avoided. BKB is like an ECC. No one will think of doing ECC for a cataract patient nowadays. So this takes us to the bubble. Basically, the bubble is a BKB. Exactly the same size. When someone plans a big bubble, they plan it as size-wise as BKB because of the risk of conversion is always there. And with time, we have a lot of patients here at KKESH that showed that even big bubble lamellar tend to have ectasia with time, progressive ectasia with time, basically because of the size of the graft. And to enlarge a big bubble is a nightmare. And the risk of perforation is always there, especially if the type of the decimate detachment was a type 2 big bubble, which usually can rent very easily and is nearly difficult to retrieve. So nowadays I don't do the bubble at all, though when I started doing the lamellar, I started doing big bubble. The other point is regarding the residual stromal thickness. Some people are fond of numbers, and they tend to give numbers as guidelines for the others. For example, if your residual stroma is so, then it is so. If your residual stroma is so and so, but I don't agree on this. And we have a lot of patients in whom the residual stroma is evidently thicker than 60 micron, but regular. And they have very good vision. The key is not the thickness. The key is how uniform the stromal thickness is, residual stroma. And a good example is LASIK. LASIK, the residual stroma is 250, 200, 300 something. And a flap is sitting on that, and the patient can see better than 20/20. So it's not definitely is not the thickness, but the smoothness of the interface.
If you allow me to comment, I would say thank you so much for your comments. They are very valid. They are enriching the lecture. So all the problems that you've mentioned with big bubble DALK can be tackled with mushroom LKP. So let's start with the diameter. So when you're going into a diameter with a mushroom shape DALK, you can go up to, nowadays Joe told me that he's going up to 87529. All right. However, you're cutting deep. Your intrastromal tunnel is very deep to the DM. So the success rate based on evidence yet حتى الآن is 100% success rate. Even if you didn't get your big bubble, you are very deep into the stroma. You can do some dissection and they can remove the remaining stroma. Even if you perforated in such cases with a large graft like sharp, your posterior amount, the posterior opening is around 6 millimeter. So the posterior clearance is 6 millimeter and your anterior graft is 9 millimeter. And Buzin showed a study that the outcome of converted mushroom shape DALK into PK is better than other cases. So this does not preclude you actually from doing large diameter. Maybe this is an option to revisit the big bubble with the large diameter.
Thank you very much. But you know what? I think I encourage people doing surgery with the least possible equipment. So when I do the lamellar, I use 57 blade and 0.12 and the patient. Anesthesia, of course. So to solely depend on Femto, I strongly discourage this. You can use it in some difficult cases, exceptional cases, that is to be done every now and then. But to solely depend on your Femto, I strongly discourage this, even in cataract surgery. Regarding you, it's okay that if you cut a disc of the endothelium and then yet leave a rim of it sounds fine, but so far I don't need to do. Sometimes I go in dissection 8.75 manual trephination.
Yeah.
Injecting deep into the stroma to facilitate decimal detachment, still yet decimal detachment. If it happens that you get type 2, there is actually no control of which type of decimal that you can get, right?
In the cases published, the series that we've done, all of them were type 1, except one case was type 2 and type.
If they publish, for example, 50 cases, we're talking about thousands. And for someone to claim that the success rate is 100%, I totally disagree with this.
I'm talking about the series. I agree with you, but
because when it comes, we are doing cases here, and we're talking about things that we are going to do next day on our patients.
Okay. But with manual, it's so deep. I'll leave some space for other questions. But with manual, you're doing, first of all, Dr. Umar, you're an amazing surgeon. That's one. That's a fact. Second thing, if you want to achieve the mushroom shape manually, and you want to reach deep, and you want to do big bubble, I think it will take 4 hours. That's one.
I'm not aiming for this.
Just give me a second. The pre-dysmatic, and I said pre-dysmatic DALK technique is crucial for any anterior segment surgeon. You need to learn the manual technique. However, we should give a space for, if you can achieve very large refractive surface and give the patient a best outcome with deep dissection. Go ahead.
Dr. Mohammed.
We'll leave some space for questions.
Dr. Mohammed.
Hello.
Thank you very much for a very informative lecture
in
a common disease, and also all type of modality of approach and treatment. I was lucky to start this LKB with the superficial keratectomy, and we were just only doing superficial and it was extremely good results and good outcome. Then the changes of procedure was taking place from time to time with advance of technology till what we reach nowadays, and which is extremely helpful for the surgeon. All techniques, two important things. To remove the scar, this is important. Second thing, for the ectasia, to put it back to the almost normal situation. And this is the key for the whole LKB, whatever you do, this is the key for the treatment. Second thing, when you remove these things, it has also the surgeon technique, because suturing is an important factor to minimize the astigmatism and also these things, and as well as the follow-up, because follow-up, what I'm saying, just topography guided suture removal. We need this to remove suture according to topography and to minimize astigmatism as much as we can. Fortunately enough, nowadays I'm doing just only one shot per desmet, just only from the beginning to remove the whole thing and to leave desmet without laser, without anything, just only manual. So skills is important for the treatment. Also, to have the new advances in technology is very important. Sometimes it delays us rather than helping us. You go to the Femtosecond room, then shift patient to the surgery room. I hope there is a machine which can do it in the same room without moving, or the room will be prepared. I know there is. Will be prepared. I'm talking about our hospital now. Will be prepared to just only do the Femto and same time do the graft, and that's it. So this is important. So we keep always the door open for discussion. Always improvement is important. Always skills is important. And also patient education is very important, because some patient will have low suture with abscess, with all these things, and will come to you after 2-3 weeks waiting for the follow-up, or there is no system which give them exact follow-up to take care of suturing, to take care of everything. Thank you very much for this informative lecture.
Thank you so much.
And I hope the door will be kept open for new advances, because the technology is improving fastly, and today what we believe, might be tomorrow something will change it.
Okay.
Thank you very much again.
Thank you so much.